Welcome to the ophthalmology rotation.
I'm Dr. Wendy Huang.
And I'm Dr. Fintelman. I've been at Midwestern now for 5 years, and Dr. Wong joined us.
Just started last fall.
I'm cornea cataract refractive.
And I am cornea uveitis, pediatric ophthalmology, and adult strabismus.
Perfect. So as you can see, lots of overlap, and the other ones are pretty obvious who does what. Our pictures, although both of us now look different, I don't think you'll have any difficulty recognizing who's who.
So collaborative care, the idea of this clinic is to demonstrate that there's support between specialties, between ophthalmology and optometry, and to basically demonstrate the team approach where each specialty really kind of shines in their own right and manages to give optimal care for patients in a setting that's both supportive, very open to learning for you guys and also for us as the ophthalmology side of things, and basically gives you a chance to get a taste of co-management.
Right. And my goal setting up or working at Midwestern was, in a sense, to try and present the best way that optometrists and ophthalmologists can work together, each to their limits of what you're capable of. So this rotation is supposed to push you. So if you're comfortable, you're probably doing something wrong. If you're always uncomfortable, you're probably also doing something wrong. So it should be a mix of, hey, I can do certain things, but other ones I still need to learn. And again, this is all for us to work together. Thus, to truly create a Midwestern model.
Yes, this is a very unique model, and hopefully you appreciate its depth.
Things that you'll see, one bunch of procedures. In the office, we have a laser room. For now, there's YAC, SLT, LPI. Shell laser removal, I try to avoid as much as I can.
Same, don't love them.
Pterygium removal, we do them in our procedure room. ICL placement, same.
Cross-linking, we perform that in the office and also in the procedure room. You'll see kind of how that's split. And then refractive surgery, we right now are doing them off-site, but also are hoping to now have it on-site.
And the reason why it's hopeful is Midwestern, we will know when it's ready, when the room is actually open. But the plan is for the renovations to include a refractive suite. In the operating room, you'll see all sorts of different procedures, anterior segment heavy, cataract surgery, cornea transplants, glaucoma surgery,
strabismus surgery, IOL exchanges, and also vitrectomies.
And, other things like removal of tumors, squamous cell carcinoma, melanoma, reconstructions of iris, secondary fixation of IOLs. So pretty much anything that can go wrong in the front part of the eye, we have probably worked on. How is the clinic different? I guess overall you'll see how the fourth year is different from third year. The biggest difference is one is pathology driven.
Also with that, there's a lot of complex diagnostic testing involved, much different than what you may have experienced previously, and also a lot of treatments because this is a pathology driven clinic. And of course the in-office procedures that we mentioned, and then also perioperative care. So you'll get the chance to kind of see what patients look like pre-op and post-op and what the procedures actually look like immediately after surgery and get a sense of how patients heal.
And the whole goal of this rotation is for you to get a true sense of a patient, taking care of a surgical patient before, meaning how do you counsel them, how do you evaluate them, how do you treat them, how do you refer them, to during the surgery, what actually happens, to then what is the recovery period, what's the post-op period, what's the long-term care, and putting these things together. And that's also how the diagnostic testing fits in. So we're trying to make you think clinically, as a patient comes in with problem A, what diagnostic test should I order to help with the diagnosis of this problem, and then how can we treat this problem?
So that lends to our expectations. So the flow sheets are really meant to provide a guide, but they're not all inclusive and they're not always entirely pertinent to the patient. So you can't really use it as just something that you can plug in and use without thought. So, but they are there as a guide to really kind of get you started. And also with these expectations, we hope that you will review all the referral records, all the visits, and all the testing prior.
And the flow sheets, again, you're supposed to understand them, meaning ideally at the end you should be able to write the flow sheets yourself. You're not supposed to just read it mindlessly, but you'd be like, oh, why is this specific request there? Why is it set up that way? Why do we ask for certain testing? And obviously understand the testing that we ask for. Meaning, as an example, patient comes in with complaining of blurry vision in the morning, you realize they have Fuchs and corneal edema, you do an endothelial cell count, you should understand what the endothelial cell count means and why we got it, and then what the treatment options there are.
And then for history, this is a pathology medical clinic, so getting a history that's pertinent to the complaint at hand is very important. And it's really important to go to try and target that history. And that's something that you will develop over time in the clinic. That's part of the clinical skills that we hope to kind of bring out of you. And we'll go through that a little bit more in this talk. And then the exam, you guys have been practicing the exam for quite some time, but actually doing the exam in abnormal eyes and kind of parsing out what is normal for them and what is abnormal for them is going to be something that you'll also develop as well. And then determining the workup and testing based off of your exam and history, and then creating, of course, the most important thing, the organized presentation, how to organize your thought, how to analyze what you're seeing, how to present it to yourself and to us to determine a logical treatment.
And everything is targeted towards the chief complaint and your problem, right? So you should not, if a patient comes in, again, picking Fuchs because it's easy, but if you have somebody with Fuchs, it's not that important what their prenatal care was. It's not pertinent to that particular problem. However, in pediatrics, it would be very pertinent. So again, you need to understand it's not comprehensive everything, it's targeted, it's focused.
So this is what the intro to the flow sheets looks like. Each of those little tabs has a link to each section. Then we'll just kind of go through. So the first part of the section is specialty testing, and what this basically shows is all the testing that we recommend for this particular consultation. However, you don't necessarily need to do them all, especially if the patient has had previous testing prior. So what you should be doing is thinking about why you're doing the test.
And as an example here, so one, you're trying to get a pentacam. Why? Because we use it for refractive testing and for the calculations of the IOL. Now here you also sometimes see one, billable or not, we'll review that in a second, and two, the dot phrases are just what brings up a template basically in your notes. So pentacam, is it billable for cataract? No. Is it billable if the patient also has RK? Yes, because then they have a corneal opacity / corneal scar. So one of the other hopeful ideas or goals for this rotation is that you will understand when you can bill or what you can bill testing for what diagnosis. And if I walk down, so I already said pentacam, let's go to the next one, keratograph. Dry eye will affect measurements, will affect the outcome of surgery, hence it's important to make sure the patient does not have dry eye.
And then next is IOL master. I think that's pretty self-explanatory. You're basically getting all the numbers that you need in order to do the IOL calculations, but it's also a good measure to cross-reference to pentacam. So it is important to get both. And then, so the missing information from an IOL master for the pentacam is basically sometimes you can get the A scan, the axial length measurement, better than the pentacam. So there are certain things that each machine does better than the others, and that's something you'll get a sense of on the rotation.
And which is again important for your practice. You need to understand what your tools can do, what they can diagnose, because you can only diagnose what you measure, and if you know that a certain tool can't measure what you want, well then it's a useless tool. That goes to the OCT MAC. It's important pre-op that we know if a patient has an ERM or macular edema or if they have macular degeneration. However, as an interesting side note on billing, you can bill if you have a diagnosis. Can you bill OCT just for the diagnosis cataract? No, you can't.
And then there's the Optos, which I'm sure you're already familiar with. So I don't think we have to go too much in depth with that. Specular microscopy, the endothelial cell count, it's really important to get this pre-op because, of course, with cataract surgery or any intraocular surgery, there's a certain amount of endothelial cells that you will lose. And so having a sense of what the risk is when going in and doing surgery is part of this workup. So of course, if they have a lower endothelial cell count, then you might want to counsel them a little bit differently in terms of the risk of needing, say, an endothelial transplant afterwards. So that's just an example of knowing why you're doing the test and what it's for. And then autorefract, I think you guys already kind of know why we have that.
But you'll learn more about the limitations of autorefraction. So as an example, autorefraction in a corneal patient, keratoconus, you probably might as well ignore. But it's a nice starting point for a normal patient. And the reason why refraction is still important even in cataract is one of the requirements for cataract surgery is that it cannot be corrected with glasses. So that needs to be documented. So to summarize again, the special testing is why are you doing it, what are you doing,
and how to interpret it.
The standard exam, again, pretty self-explanatory here. Chief complaint, and the complaint, please, is relating to their activities. So for cataracts, okay, I have blurry vision. Well, what does that affect? What does that interfere with? There are a few questionnaires that we have in here. Quality of vision questionnaire. There's an OSDI, ocular surface disease index. The DELT questionnaire is only for patients who are interested in getting out of glasses. So as an example, would I want a DELT questionnaire on a patient with a cornea transplant, keratoconus? No, do not do that. So again, you need to understand what it's for. The other reason, or why it's sometimes not helpful, is if the patient already has a very clear idea of what they want. The DELT questionnaire is there to get the conversation started. So please read it, see what you think of it, see how you would use it. There's one more questionnaire that we use now that's not on here yet, which is a documentation of complaints, meaning of visual complaints related to cataracts.
And then next is that just taking the case history. So it's really important to target your case history. For example, in this example of the flow sheet for cataract surgery, it's really important that we know if the patient has diabetes, of course, because of the risk of macular edema, and then prior surgical history. So if a patient has had previous intraocular surgery and say has responded to steroids in the past, that does dictate management. So the history is important. Knowing the components of the history to ask is something that you will develop, but hopefully this will kind of serve as a guide for you. And then, of course, when you see different pathologies in clinics, say uveitis patient, the history is very extensive because of just the nature of it being an autoimmune disease. And then other patients that are a little bit more complex, versus, say, a patient who has an isolated issue like Fuchs, the history is going to be very different in how you take it. So just kind of knowing how to adjust your history, because you could ask for days about everything, and that's really not realistic in practice.
And here's another example of what's more relevant to this particular complaint. If a patient comes in for a cataract and they're interested in light adjustable lens, while documenting the dilated pupil size is important, because one of the requirements for a light adjustable lens is a pupil size that dilates at least, ideally 7, but at least 6 millimeters. And if that's not available, the patient's not a candidate for a light adjustable lens. Similarly, back to Fuchs, if a patient needs an endothelial keratoplasty, and then it's important to know, do they have a cataract? Because then we would do both at the same time. Or 2, what kind of lens do they have? Certain lenses will respond differently to the surgery. They can either dislocate, they can opacify, we can expect vitreous depending on where the lens is. So understanding all these nuances, I hope you will gain from this rotation.
And then going back to after your exam, you can go back and ask more questions. So that's how you can kind of target your actual history, is by looking and seeing what pathology the patient does have and asking again. So oftentimes we'll have patients come in and they're presumably here for a cataract surgery eval, but you look in and by the time you've done everything else, it looks like they've already had cataract surgery. So things like this happen on a regular basis. So taking a look first isn't always the worst idea to kind of get a sense of, what you need to be asking and what testing you need to consider.
However, stay flexible. It's not I've had students ask for half an hour beforehand, what is this? What is that? What is this? And again, you can do this forever. Get information, but then wait for the patient and adjust based on their complaints and based on their history. Otherwise, again, you will spend time on something that's not helpful. So this is again the how, the why,
and the post-exam history. So assessment and plan. So this is the most important part of the note. Most of the time, most people will jump to this, especially if you're referring. So it's really important that you are concise and that you also include every single diagnostic point that is pertinent to that day's exam, especially when it comes to billing, and we'll go over that as well. And of course, in terms of making sure that your goals are clear with the patient. And just keep this in mind, the patients are able to read your notes afterwards. So you want to make sure that everything that you write in there is clear and also pertinent. So for the assessment of plan, an example in this particular flow sheet, we're talking about the refractive goal. So what kind of vision that they're aiming for, either single vision, monovision, things like that. And then discussion of their dry eye treatment before and after surgery. So basically, this is kind of delineating all the factors that you want to address prior to cataract surgery, so that you're doing a thorough pre-op workup and getting them thoroughly prepared for cataract surgery, and also documenting the consent and everything you've discussed. So it's really important to put that in the assessment and plan so that you can reference that later. Say if the patient says, "Oh, you didn't discuss this with us." You have it in your assessment and plan. They have it accessed in their records. It has been discussed, and it's a lot easier to go back and show that to the patient, and also know where your starting point is with them in reopening the discussion.
And the other important part here is the understanding, again, what's in the plan. So AIM means the refractive aim is defined as what refraction would a patient need for best spectacle distance vision. As in, if a patient wants near vision, their distance aim or their aim should be what? Can you guess? So for us, that aim is defined as -2. And the reason, for example, is you oftentimes think in the glasses that you would prescribe. And again, I repeat the definition. The definition of aim is what correction they would need for best distance vision. -2 would be without glasses, they're nearsighted. With glasses, they see just fine at distance.
Okay, so let's move on to the other component of the expectations. Just to reiterate, we do expect you to review everything prior to seeing the patient. So all the referral records, all the previous visits, all the previous testing. This will actually really inform you as to how to approach the patient, even if they change their mind and decide to tackle a different system or a different symptom that they were not originally scheduled for. History, we discussed this a little bit, but basically focusing on the current chief complaint. So the idea of a chief complaint is really key. You could go on for hours with a patient going over every single problem with their eye. But you have to tackle what they want addressed in the moment and what they're there for. Remember, this is a high pathology clinic. There's going to be a lot of other things going on, but if the person with their third corneal transplant is complaining of dryness, you deal with their dryness. Not the transplant, not the tube that's in the wrong place, all the other things that you will see and get confused by. And then you will understand, based off of their complaint, what pertinent positives and negatives to ask. And then contributory and non-contributory factors. So as mentioned before, say the prenatal history of somebody is not important for somebody with Fuchs. You will know what factors are important to address just from your studies. Use your studies, use your common sense, and that will guide you for these visits. And then also revisit and re-ask questions.
And all that will basically help you to organize both your questions and the organization that you present further, and just create a picture of the patient in your head.
So the exam, form your differential first based off of the history, and then tackle your exam. You have demonstrated and practiced many components of the exam. You could be examining the patient for 3 to 4 hours if you did every single thing you can do for an eye. So you really should focus your exam because it's not realistic to do everything. This is an example of Munson sign. I am not going to look for Munson sign in a patient who's here for, say, amblyopia treatment. Well, maybe.
However, I was going to say,
okay.
you will sadly see patients diagnosed with, quote, amblyopia when they're 15.
Yes.
Because they have a 7 diopters of cylinder and they actually have keratoconus.
Okay, maybe that wasn't the best example. Okay. All right, so we'll go with 90-year-olds.
I was going to say, fair enough. But I think you should look at what's related to your diagnosis, yes, but you should also be able to recognize something obviously pathologic. So patient comes in for dry eyes, you should still be able to recognize they have a retinal detachment, for example, even if the patient is not complaining about it.
Yes.
So it's a little bit of both. So again, this is difficult. We're not saying this is easy.
But this is part of forming your differential and doing your exam. So somebody might complain of symptoms that might be typical for dry eye. You start to do the dry eye workup, and as you mentioned, there's a retinal detachment. So your differential has changed. So you got to search for clues in terms of what they're telling you they are seeing, and then also find those clues in your exam and then look further. So say undilated, you see that there may be in the anterior vitreous, there's a little bit more pigment than you're used to seeing. And so dilated, you're going to look a little bit closer, you're going to look more at that pigment into the anterior vitreous and hopefully find that tear. So things like that where it wasn't obvious when you first started, and then you just see a little something different in your exam, and then you kind of search for that. That's what we mean by doing a focused yet complete exam.
And the workup and testing, again, base testing is based on examined history. Understand why you're doing a test, and please understand what the test means. I am saddened by students that I ask, what did the pentacam show? And they say, well, I didn't look at it. And in my mind, I was like, you did the test. You were right there. It should take you 30 seconds. And if you have trouble interpreting it, please ask. That's another benefit. You can ask us. Happy to explain, happy to review, because that's another opportunity for you to learn.
Yes.
And last one, important one, super important, organize your presentation. Summarize symptoms, findings, assessment, and plan. Complaint, symptoms, contributory medical history. Don't tell me everything. Tell me what I want to hear. Current treatments.
The exam, just based off your exam, what testing you chose to do and the results, your interpretation of those tests, and then based off of that, what your plan is. So we want you to not wait for us to give you a plan. We want you to formulate your own plan because that's what you will be doing after the year is complete. You will be on your own. There will not be somebody to ask, what's the plan? So our hope is that you use this as kind of a test environment in a safe space where you can really think for yourself, demonstrate a plan. If the plan doesn't work or it doesn't make sense, we'll tell you, and that's part of the learning process.
Right. Here, the worst thing is I'll be disappointed. Outside, the worst thing is you blind a patient or kill someone. So I think this is preferred.
Yes, this is definitely preferred.
And so the organized presentation, I love this, but that's exactly right. It should tell a history. Otherwise, you already lost me. So if you don't capture my attention, the first sentence should be like the headline of a newspaper article or whichever article you want. Grab your attention. So, and the summary is oftentimes you have a 1-sentence summary, right? So you have as a cataract example, fine 89-year-old patient comes in complaining of 1 year of decreasing vision with a new onset of glare, which makes it difficult for them to drive at night. Great, already have that. And then you can tell me exam shows 2+ an S and dilate well, no other pathologic factors. Plan would be cataract surgery with aim of distance vision. And that's the end. That's already a very short summary. Obviously, there's more depending on how complex patients are.
So you are doing this every day. You are making an organized presentation every day when you tell a story. So this is not a new skill. Just naturally use this skill when you're thinking about clinics. So this is just a very kind of very rudimentary example of Goldilocks. So chief complaint. Family notice that the porridge is half eaten and the chair is broken. Contributory history. They left the door unlocked and food out in the open. Current treatments, none. Exam, let's go take a look and see what's going on. Everything's broken. Goldilocks is in Baby Bear's bed. Testing results, let's poke her and see if she's awake. See if she's alive. Plan. Call the police, buy locks. Goldilocks is now looking at juvie. So you do this all the time. You can do this. Next is billing.
Next is billing. Sorry, it never ends. But again, without billing, you don't get paid. And if you don't get paid, you can't do your job. So you should understand the billing levels. And in our clinics, it's all 99 codes. It's not eye exam codes anymore. It's all medical codes. We can review the details, but at Midwestern, please use medical codes. But for a medical code, the first diagnosis should not be presbyopia or myopia. It should be a medical diagnosis. All the medical diagnoses are important. Do not say cataract and then list, and the patient has AMD and dry eyes and keratoconus in your plan. These are all separate diagnoses. More diagnoses increase the level of your visit. The visit level is related to how difficult and complex the patient is and how difficult the treatment is. So if somebody is going blind right now, they need surgery right now, that's a very high level. Somebody is doing fine with maybe dryness and they're doing amazing is a very low level.
And then there's the global period. It's good to know the global period of each of the procedures so that you can get a sense of what you can and cannot bill. And then proper documentation. So this is really important, especially for the coders and the billers, and you'll encounter this in your practice, of course. But you do have to document and word things a certain way for them to actually accept the diagnosis that you've been given. So you just can't say pterygium and then not have a pterygium in your exam. And then especially when you're documenting for surgery, like say for cataract surgery, there are certain qualifiers that they want written in your plan and also your documentation. They want to know that you cannot refract this patient better. Saying 4+ NS is not enough. They really want to know that subjectively this patient needs the surgery. So, and it's all different measures that the billers and coders will look for. So knowing that to make their lives easier and your life easier is the best way to do.
And the key, this is why cataract is one, it's very frequent, but it's a very good example, is not only should the plan make sense, meaning patient's affected, they have a cataract, we recommend removal. It should also say, and the removal, we expect the removal to help the patient. Otherwise, again, why are you doing this? And that's a good example of how any treatment should be. Dryness, low tear lake staining, patient tried tears, let's do plugs, we expect the plugs to help.
And then your goals. So your goals, what we hope that you get out of this entire experience is a true co-management experience between optometry and ophthalmology. We want you to really develop your clinical instincts and skills. So think independently, use all the things that you've learned so far and implement them, and then become really familiar with the perioperative exams, as we mentioned. Remember, you are the optometrist of the clinic. So this is attending level almost skills that we want you to try and practice. Basically, you're the optometrist, we're ophthalmology, we're relying on you to kind of give us a sense of what your interpretation of things are and what and clue us into what we need to do for you as the ophthalmology side of the practice.
And it's also one way for you to practice or to test if you like that kind of collaborative care.